GIT, and abdominal condition. We discuss in this first lecture the acute abdominal condition, how we can investigate, and how we use different radiological methods to investigate acute abdomen. Following the history and the clinical examination, plain film radiographs have been one of the first and most useful methods of further investigation. So, the most available and widely used radiological method for investigation of acute abdomen is the plain abdominal radiograph. CT scan is a good alternative if available for the investigation of acute abdomen. In certain specific conditions, such as in acute cholecystitis, ultrasound has become the initial imaging technique of choice. يعني احنا ما نقدر نحدد في طريقة واحدة for investigation of acute abdomen. يعتمد على احنا شنو استفادينا من الفيزيكال examination ومن الهيستوري، على ضوء نقدر نحدد احنا which type of radiological investigation we can use. Most widely used is the plain film. CT scan is a good alternative, and in certain specific conditions, the ultrasound play an important role. The first radiological technique we discuss is the radiographic techniques. Different radiographic technique can be used to assess acute abdominal patient. The first radiograph we can be used to diagnose acute abdominal condition is the chest X-ray. Chest radiograph can be regarded as an essential exam for any patient presenting with an acute abdomen. يمكن واحد يتساءل يقول شنو السبب انه انا استخدم chest X-ray for examination of acute abdomen? There are many reasons for using of chest X-ray as a tool for investigation of acute abdomen. First, the erect chest film is the best radiograph for showing the presence of a small pneumoperitoneum, particularly on the right side between the liver and the diaphragm. It is superior to the erect abdominal film for this purpose. You know that the chest X-ray is used for assessment of the lungs and the mediastinum. It can be used for assessment of the acute abdomen, particularly in pneumoperitoneum, because both diaphragm and the upper abdomen should be present within the chest X-ray. So it is superior to the erect plain abdomen for diagnosis of pneumoperitoneum. The second reason, a number of chest conditions may present as acute abdominal pain and mimic acute abdomen. Patient may present with basal pneumonia. The clinical presentation is resemble acute abdomen. So by using a chest X-ray, we can assess the basis of the lung. So it's easy to diagnose the cause of such acute abdominal pain. The third cause for using of chest X-ray is that acute abdominal conditions may be complicated by chest pathology. For example, pleural effusion frequently complicate acute pancreatitis. مريض عنده acute pancreatitis present with acute abdominal pain. When we use chest X-ray, we can assess pleural effusion as a complication of the condition. It can be regarded as an essential exam for any patient presenting with acute abdomen. The second radiograph we can use for assessment of acute abdominal condition is the abdominal radiograph. Two types of plain abdominal radiograph can be used. The supine abdominal radiograph, second erect abdominal radiograph. A third radiograph can be used, which is the left lateral decubitus film, but it has a very limited uses. The most widely used plain abdominal radiograph is the supine abdominal radiograph and the erect abdominal radiograph. The supine abdominal radiograph is probably the single most useful film. It is allow the distribution of gas and the caliber of the bowel to be determined. نقدر نشوف الكاليبر of the bowel ليس فقط الاير fluid level. A horizontal X-ray abdominal radiograph in erect position is frequently used. It can show the presence of multiple fluid levels and free gas and can add more information to diagnose the condition. So in erect plain abdominal film, we can see the air fluid level. In supine abdominal radiograph, we can see the caliber and the anatomy of the bowel. In pneumoperitoneum, the definition of pneumoperitoneum is the presence of free air within the peritoneal cavity. The demonstration of a small pneumoperitoneum in a patient present with acute abdominal pain is one of the most significant signs in medicine. It is possible by careful radiographic technique to demonstrate as little as 1 ml of free gas on erect chest or left lateral decubitus film. شوفوا هنا شنو ذكرنا من شرحنا النيوموبريتونيوم انه نستخدم chest x-ray for its diagnosis, or we can use left lateral decubitus abdominal film for a small amount of free gas. However, the drawback of this technique that the radiographic technique and positioning are important. يعني أنا مو رأسا آخذ المريض أوقفه وأسوي له chest x-ray أو أنيمه أسوي له left lateral decubitus film. لا, الpositioning والtiming is very important. The patient should be in position for 10 minutes before the film is taken. Why we use this long time, 10 minutes before we take the x-ray? It take this time for free gas to rise to the highest point in the abdomen. وطبعا the highest point in the abdomen on the erect film is the right hemidiaphragm. So فإذا شنو نقدر نستخدم to diagnose a pneumoperitoneum? We can use erect chest x-ray, left lateral decubitus abdominal film, and we can use supine position. طبعا نقدر نستخدم الإركت plain abdominal film لكن نقدر نستبدلها أحسن بالإركت chest. So what are the radiographic sign on the erect chest or left lateral decubitus film or supine position? On erect chest x-ray, gas is relatively easy to detect as a curvilinear radiolucency under the right hemidiaphragm. يعني أول sign نقدر ندور عليها بالإركت chest x-ray هو area of curvilinear translucency under the right hemidiaphragm. واحد يسأل ليش ما ندور عليها under the left hemidiaphragm? On the left, free gas can be difficult to differentiate from stomach and colonic gas. عارفون أن موجود الغاز air bubble under the left hemidiaphragm, so it is difficult to differentiate between the free gas and the gas of the stomach or the colon. It is easier to be detected under the right hemidiaphragm due to absence of any bowel gas in a normal patient at this position, and because the right hemidiaphragm in most of the population is higher than the right hemidiaphragm. So in erect chest film, we can see the curvilinear translucency under the right hemidiaphragm. On the supine film, we can see the outer as well as the inner wall of a loop of the bowel. This is called regular sign. It is a valuable indication of pneumoperitoneum. What is the regular sign? It is a sign of pneumoperitoneum seen on supine position, supine plain abdominal film. It indicates visualization of the inner as well as the outer wall of the bowel. This is a chest x-ray in erect position showing a curvilinear translucency under the right hemidiaphragm. This is the right hemidiaphragm. You can see it. This is the here the left hemidiaphragm is not very clear seen. You can see this curvilinear translucency under the right hemidiaphragm, which indicate pneumoperitoneum. This is another example of pneumoperitoneum on chest x-ray. This is the white line represent the right hemidiaphragm. The this white line on the left represent the left hemidiaphragm. This curvilinear translucency and this curvilinear translucency is indicate a sign of pneumoperitoneum. This is also bilateral case of pneumobritonium, in which these are the diaphragms on the right on the left, and these are the translucency under both hemidiaphragm, indicating the presence of pneumobritonium. This is the left lateral decubitus full. This left lateral decubitus full. This is the abdominal wall, the lateral abdominal wall. هذا الخط الأبيض يمثل لي lateral abdominal wall. And this linear translucency under the abdominal wall indicate pneumobritonium. Left lateral decubitus full is useful for detection of small pneumobritonium as little as 1 millim. This is a supine plane abdominal full. In a normal plane full without presence of pneumobritonium, we can only see the inner wall of the bowel due to the presence of the gas. Only the inner wall of the bowel can be seen due to the presence of the gas. Visualization of the inner as well as the outer wall of a bowel loops on supine plane abdominal film indicate the presence of pneumobritonium, and this sign is called the regular sign. This is called the regular sign. This translucency indicates the presence of air. This is the outer wall of a bowel. This is the inner wall of the bowel. Visualization of both walls indicating the presence of pneumobritonium. Other sign that can be seen on the supine plane abdominal film is the cubular sign. What is the cubular sign? Large amount of gas may accumulate beneath the diaphragm. This is called the cubular sign, and this is seen on the supine, not on erect plane film. Or a large amount of free fluid may be accumulated in the center of the abdomen over a fluid collection, and this is called the football sign. Large amount of gas accumulated over a fluid collection on supine plane film called the football sign. The cubular sign is visualization of the large amount of gas under the diaphragm. This is called the cubular sign. So this is the first acute condition of the abdomen. It is the pneumobritonium. Can be diagnosed by using of a plain abdominal film. طبعا CT scan is more sensitive to detection of a small amount of free gas if available. If not available, we use the plain abdomen. We use the plain films. The plain films, either we use erect chest X-ray, we can use the left lateral decubitus plain abdominal film or the supine plain abdominal film. On the erect chest, easy to visualize the lesion under the right diaphragm as a curvilinear translucency, more easier than on the left side due to the presence of the stomach and bowel gas. These are different examples of pneumobritonium. This is the left lateral decubitus film showing free air as a linear translucency under the left lateral wall of the abdomen. This is a supine plane abdominal film showing the regular signs, which is visualization of the inner as well as the outer wall of a bowel loops. The second topics we discuss in this acute abdomen is the intestinal obstruction. Two types of intestinal obstruction can be present. The first is the small bowel obstruction. The second is the large intestinal obstruction. So, what are the causes of small intestinal obstruction? Anyone can be answer me? Anyone can answer what are the sign or what are the causes of small intestinal obstruction?
دكتورة adhesions
Yes.
obstructed hernia.
Yes, the most common causes of small intestinal obstruction is adhesion and hernia. طبعا in developed countries the commonest cause is adhesion. In the underdeveloped countries the most common cause is the obstructed hernia. So complete obstruction of the small bowel usually causes accumulation of both gas and fluid with dilatation of the small bowel loop and reduction in the caliber of the large bowel. As a pathological condition, as what will go inside the body in small intestinal obstruction, راح يصير عندنا dilatation of the small bowel loops, accumulation of both gas and fluid, and reduction in the caliber of the large bowel. One asking why there is reduction in the caliber of the large bowel. Anyone can answer me?
دكتورة because absence of gas bubble.
لا ليش احنا نشوف ريدكشن اي ليش يصغر الكاليبر مالت اللارج باول بيصير عندي small intestinal obstruction؟ شنو السبب؟ because the gas will reaching to the large bowel through the small bowel. So if the small bowel is obstructed, how the gas can reach to the large bowel؟ راح تقل كمية الغاز اللي واصل لللارج باول، وراح يقل كمية الفلويد اللي واصل لللارج باول، فلذلك راح يصير عندي reduction in the caliber of the large bowel. So, how we can diagnose small intestinal obstruction? We can diagnose after the clinical history and examination by using of radiographic technique. What we can use for diagnose small intestinal obstruction? What tools of radiographic technique we can use?
دكتورة هو
Anyone?
abdominal film
يعني
CT scan.
plain abdominal film, yes, and we can use CT scan as a good alternative for diagnosis of small intestinal obstruction. Two types of plain abdominal film can be used for the diagnosis of small intestinal obstruction or large intestinal obstruction. The erect film, the erect plain abdominal film, and the supine plain abdominal film. Both these films can be used for diagnosis of intestinal obstruction. So, what will we see on a plain abdominal film? On a plain abdominal film. Okay, so we can see dilated gas-filled loops of a small bowel on supine radiograph, and multiple fluid levels are present on erect film. So, what are the signs on a plain abdominal film that indicate intestinal obstruction? Multiple dilated bowel loops on supine film and multiple air fluid level on erect film. In this film, this is a plain abdominal film in erect position. How we can say this is erect position? Due to the presence of the air fluid level. This is the thin line separate the air, which is the translucency, from the fluid content at the bottom, indicate air fluid level, and this can be only seen on erect position, not be seen on supine position. Presence of multiple air fluid level indicate a case of small intestinal obstruction. On supine plain abdominal film, we can see we can see multiple dilated bowel loops. يعني جاي يشوفون هنا we have two films. This is erect position and this is supine position. In erect position, we can see the presence of multiple air fluid level. On supine film, we can see multiple dilated bowel loops. Multiple dilated bowel loops. In this film also, this is erect position, we can see multiple air fluid level. Multiple air fluid level. طبعا هسه راح نجي شلون نقدر نفرق انه هذا small from large bowel. ان شاء الله بالدقائق القادمه نقدر نفرق بيناتهم. There is a specific sign that can be seen in a small intestinal obstruction. Also, this is erect, this is supine. يعني جاي تشوفون الفرق بالاركت شنو يطلع عندي؟ يطلع عندي الاير فلويد ليفل، ما يطلع عندي الكاليبر مالت الباول. بالسوباين فورم جاي يطلع عندي multiple dilated bowel loops. طبعا هاي الخطوط البيضاء اللي جاي يشوفوها شو تمثل لنا؟ تمثل لنا الفالفولي كونيفنتس. هاي الخطوط البيضاء اللي جاي نشوفها متصلة كاملة from side to side is the valvuli conjunctivus. هنا كلش واضحة جاي تطلع لنا هذه valvuli conjunctivus, which is the normal ridge mucosal ridge of the mucosa of the small bowel. هنا أنا هم جاي تطلع عندي بالإركت بوزيشن. نفس الشيء هنا. This is erect, this is supine, multiple air fluid level can be seen, and here the dilated bowel loops with the presence of the valvuli coniventus. Another, we say that there is a specific sign that occur in small intestinal obstruction. In dilated small bowel, which is almost completely filled with the fluid. قلنا احنا عادة من يصير عندنا small intestinal obstruction, there is accumulation of gas and fluid within the bowel loop. But in cases that the small intestinal obstruction, the dilated small bowel loops is almost completely filled with the fluid, small bubbles of gas may be trapped in rows between the valvuli coniventus on horizontal X-ray films. This is known as the string of beads sign. This sign, if present, is virtually diagnostic of small bowel obstruction and does not occur in normal people. من يصير عندي small bowel obstruction قلنا بالعادة شي يجمع عندنا fluid and gas. In cases of small intestinal obstruction that is completely filled with the fluid, يعني كمية الغاز الموجودة راح تكون كلش قليلة. Small gas bubble هاي السمول translucence اللي جاي يشوفوها. Small gas bubble will be trapped in row between the valvuli coniventus. هاي الحواجز البيضاء اللي جاي يشوفون between one and the other شو تمثل لنا؟ تمثل لنا الفالفولي coniventus. This sign is called the string of bead sign. It is pathognomonic for small intestinal obstruction, but unfortunately it is a rare sign because there should be accumulation of fluid rather than gas. The second topic of the intestinal obstruction is the large intestinal obstruction. What are the commonest causes of large bowel obstruction? Anyone can answer me?
Carcinoma, دكتور.
Yes. The commonest cause of large bowel obstruction is carcinoma. 60% are situated in the sigmoid colon. يعني أكثر الcauses of carcinoma that cause obstruction present within the sigmoid colon. وطبعا انتم تعرفون انه اذا كان عندي mass بالsigmoid colon راح تؤدي الى obstruction earlier than that mass present on the right side because of the small caliber of the sigmoid colon. يعني إذا نقيس السيجمويد كولون مقارنة بالديسندنج بالترانسفيرس بالرايت بالسيكا السيجمويد كولون هو أقل diameter بيهم ف even small mass if present can lead to intestinal obstruction. Here the appearance is depend on the degree of competence of the ileocecal valve. يعني ما راح نشوف فد شيء ثابت بكل المرضى مو مثل السمول باول اوبستراكشن air fluid level multiple او اذا كان عندي multiple dilated bowel loop او string of bead sign. هاي الساينات اللي نشوفها بالسمول باول اوبستراكشن. بالlarge bowel obstruction الappearance on the plain film or on the CT scan depend on the degree of the competence of the ileocecal valve. In type 1 small intestinal obstruction the ileocecal valve is competent. يعني شنو معناته competent؟ معناها جاي يشتغل بطريقة طبيعية. It is a one-way valve allow the content to pass from the small to the large bowel. It prevent the passage of content to pass from the large to small bowel. يعني one-way direction valve. So if it is competent that it is work normally, the radiographic appearance is that of dilated colon with a distended thin wall cecum with or without distension of the small bowel. يعني هنا أنا جاي يشوفون أنا شنو موجود عندي. This is erectile. شلون عرفنا هذا erectile؟ أكو أحد كان
دكتورة
answer me?
air fluid level.
Because of the presence of the air fluid level. This is erectile. We can see a dilated bowel gas, dilated colon with a thin wall dilated cecum. جاي يشوفون هنا الكاليبر مالت السمول باول is smaller than that of the caliber of the large bowel and their absence of any dilated small bowel loops. So this is a type 1 large intestinal obstruction, the ileocecal valve is competent. واحد يقول how we can know this is a large bowel loops? We can see the peripheral distribution of the large bowel in the periphery of the abdomen, while central distribution for the small bowel. The caliber is larger in the large bowel, smaller in the small bowel. The presence of the valvuli conniventus, this is the valvuli conniventus in the small bowel, and the presence of hostra in the large bowel. الهوسترا هم هي normal mucosal ridge of the large bowel. How we can differentiate between the hostra and the valvuli conniventus? Anyone can answer? يعني
دكتورة يعني هي الهوسترا تكون بس بالبريفري تقريبا ما تصير بالسنتر مالت اللوب؟
incomplete
اي
incomplete
نعم.
يعني نسميها incomplete mucosal ridge، لكن الفالفولي conniventus شو تكون complete. هذا وحده. بعد how we can differentiate.
دكتورة المسافات بيناتهم؟
Yes, the distance between one valvuli and the other is larger than the distance between the distance between one hostra and the other is greater than the distance between one valvuli and the other. جاي يشوفون هاي الفالفولي كلش وحدة قريبة من الثانية، لكن الهوسترا بتكون المسافة بيناتهم أبعد. The third differentiating point that the hostra is thicker than the valvuli conniventus. الفالفولي تبين كخط رفيع جدا، بينما الهوسترا appear very thick in comparison to the valvuli conniventus. فلذلك عرفنا من distribution of the bowel gas from the presence of the valvuli conniventus and the hostra how to differentiate between small and large bowel loops. So this is a plain abdominal film in erect position showing a dilated bowel loops, peripheral in distribution, thin-walled cecum with absence of dilated of any bowel gas. This is large bowel obstruction. This is an example of large bowel obstruction. This is erect position and this is supine position. We can see the number of the dilated bowel loops is less than that would seen in the small bowel. يعني ما شفناها بالسمول bowel multiple. أنا تقريبا عندي 2 بهاي المنطقة وعندي 2 بهاي المنطقة. So less number of dilated bowel loops can be seen in the large bowel, more in the small bowel. The peripheral distribution of the air fluid level or the dilated bowel loop seen in the large bowel, central distribution go with the small bowel، بالإضافة إلى الساينات الثانية اللي راح نذكرها هسه. So in this form you can see this is type 1 large intestinal obstruction because of absence of the dilated small bowel loops, presence of dilated large bowel loops. This is usually distended thin wall cecum with the presence of dilated bowel loops peripheral in distribution. This is another example of supine film in large intestinal obstruction showing gas-filled large bowel loops, peripheral in distribution, thin wall cecum with the presence of the hostra and competent ileocecal valve. Why it is competent? Because of absence of dilated small bowel loops. In type 2, the ileocecal valve is incompetent. يعني هنا ما جاي يشتغل بطريقة صحيحة، جاي يعبر بالاتجاهين from small to large and from large to small bowel. So the ileocecal valve is incompetent. The cecum and the ascending colon are not distended. يعني جاي راح نشوف بالتايب 2 الكاليبر مالت السيكم والascending colon is normal. But the back pressure from the colon may extend into the small bowel, and there are numerous dilated loops of the small bowel which may simulate small bowel obstruction. So in type 2, large intestinal obstruction, when there is incompetence of the ileocecal valve, the cecum and the ascending colon is not dilated. The back pressure is passing into the small bowel, producing multiple dilated small bowel loops, and here we may mistake the condition as a small intestinal obstruction rather than large intestinal obstruction. So, how we can differentiate between small and large intestinal obstruction on a plain abdominal film سواء كانت supine or erect position. The valvuli coniventus present in the duodenum in the small bowel, absent in the large bowel. The number of dilated bowel loops or the air fluid level, it is many in the small bowel, few in the large bowel. The distribution of the loops or the air fluid level, central in the small bowel, peripheral in the large bowel. The hostra, absent in the small bowel because it is a mucosal ridge of the large bowel. Diameter of the dilated bowel loop, which assists on the supine plain abdominal film, 3 to 5 cm, 5 cm and more in the large bowel. The radius of the curvature هذا معناها انه اقيس ال radius of the air fluid level on erect film. It is occur in a small bowel. It is sorry. It is small in the small bowel obstruction. It is large in large bowel obstruction. The radius of the curvature indicates the length of the air fluid level. It is small in the small bowel, large in the large bowel. Solid feces absent in cases of small bowel obstruction and present in the large bowel obstruction. واحد يقول المفروض بالعكس يعني احنا ما نشوف solid feces بالlarge bowel obstruction. لا احنا نشوفها بالlarge bowel obstruction because the content is reaching to the large bowel. But if the small bowel is obstructed, no fluid, no gas, and no material is reaching to the large bowel, so the solid feces will be absent in the small bowel obstruction and present in large bowel obstruction. بس أحب أذكركم إنه string of bead sign, which is a sign of a small intestinal obstruction, present in the small bowel, absent in the large bowel, and it is only seen on erect film. يعني إذا سويت supine film ما أقدر أشوف ال string of bead sign. The other alternative for diagnosis of the small intestinal obstruction or intestinal obstruction in general is the CT scan. So what are the rule of the CT scan in the diagnosis of intestinal obstruction? It is the investigation of choice for suspected small bowel obstruction when clinical and abdominal X-ray assessment are inconclusive. يعني أنا أبدي بالبلين abdominal film لكن إذا ظلت inconclusive انتقل إلى CT scan. CT is highly accurate for establishing the diagnosis of the small bowel obstruction. Can define the location and cause of the obstruction and diagnosing any associated strangulation. So what are the CT signs of small bowel obstruction? It is seen as a dilated small bowel loop in the region of the obstruction greater than 2.5 cm diameter. This is Phil. Identifiable transition zone from dilated to non-dilated bowel loops. This is second. And the third sign, the presence of collapsed bowel loops distal to the transition zone. يعني راح أشوف dilated bowel loop أكثر من 2.5 cm diameter. وراها راح أشوف الترانزيشن زون اللي تفصل لي بين الأبستراكتد والنون أبستراكتد bowel loops. وراح أشوف بعدين the collapse small bowel loops which is non-obstructed. نانا هذا CT scan of the abdomen. You can see there are multiple dilated fluid and gas containing small bowel loop. هاي هنا dilated أكثر من 2.5 سنتيمتر. وراها اجت عندي هنا شنو؟ the transition zone اللي راح تفصل لي between the dilated and the small caliber bowel loop. وهنا رجعت عندي شنو هنا؟ رجعت عندي the non-dilated or collapsed bowel loop. So we look for three signs. The dilated bowel loops, which indicate the obstructed segment. The area of transition between the obstruction and non-obstructed bowel loop, and the collapse or non-dilated bowel loops. This is another example showing multiple gas-filled dilated bowel loops. Gas-filled dilated bowel loops on CT scan. And this is also a good example showing multiple gas-filled dilated bowel loops in the region of the large bowel, indicating a large intestinal obstruction. So CT scan with or without contrast is a good alternative to diagnosis of intestinal obstruction if the clinical sign or the plain abdominal film is non-conclusive. The other topics in our lecture of acute abdomen is how we can assess acute appendicitis. You know that in acute appendicitis, most of the cases is depend on the history and the clinical examination. But in a significant minority of patients, particularly the young and the old, the clinical features of appendicitis are obscure and the diagnosis is difficult. خصوصا بهاي الايج جروب اللي يكونون young or old age, and in the pregnant female or in menstruating female the diagnosis may be difficult. So how we can assess acute appendicitis? By radiological methods. Previously, before the administration of the ultrasound, they depend on the sign on the plain abdominal film. But now, the first radiological tools to diagnose acute appendicitis is the ultrasound. But if the diagnosis is a query and we do abdominal plain film to the patient, we should look for sign of acute appendicitis on the plain abdominal film. So, how acute appendicitis can be seen on the plain abdominal film? Either a normal finding، يعني نهائيا ما نشوف أي شيء بالبلين abdominal film على الرغم أنه المريض عنده acute appendicitis, but there are negative sign or normal appearance on the plain abdominal film. The lesion can cause focal ileus، يعني راح نشوف احنا dilated bowel loops in the region of the right iliac fossa that give a clue that the case may be acute appendicitis. We can see appendicolith اللي هي عبارة عن calcification within the lumen of the appendix in the right iliac fossa may indicate the case that it is acute appendicitis. Mass can be seen in the right iliac fossa. In cases of appendicular mass, we can see a mass in this region, or free air can be seen in the right iliac fossa, which may extend to the right hemidiaphragm in cases of ruptured appendix, but it is a very rare. So the signs are non-specific. It results from the localized inflammatory changes, which may progress to perforation, abscess formation, or paralytic ileus. So there are no definite signs for acute appendicitis on plain films, but if we do plain films to patients with acute abdomen, we should look for these signs: focal ileus, appendicolith, mass, or free air. So how we can diagnose acute appendicitis? By ultrasound. The technique of the ultrasound used to diagnose acute appendicitis is called the graded compression technique. The graded compression technique of ultrasound examination of the appendix. We use a linear probe with a frequency at least 7 megahertz. يعني ما استخدم الكونفكس بروب اللي احنا نستخدمه for diagnosis of the abdominal organ. We use the superficial probe اللي يسمونه linear probe which has a higher frequency at least 7 megahertz. المفروض انه انا احتاج انه more higher frequency to diagnose acute appendicitis from 7 to 15 or 20 اعتمادا على الجهاز. So we use the graded compression technique for diagnosis of the ultrasound using a probe of at least 7 megahertz. وين أخلي البروب؟ أخلي البروب at the area of maximum tenderness in the right iliac fossa. يعني أسأل المريض وين أكثر مكان جاي أذيك بالرايت iliac fossa، يشير لي عليه، أخلي البروب عليه بالتحديد. طبعا أنا أفحص المنطقة كلها لكن أركز الفحص مالتي على الاريا of maximum tenderness. ليش احنا نقول graded compression technique؟ شنو يعني هو graded compression technique؟ The graded compression technique that we use a pressure when examine the patient. This pressure is gradually increased over the area. يعني أنا أبدي ببريشر خفيف بالبروب، أبدي أضغط ببريشر خفيف وأبدي أزيد هذا الضغط تدريجيا at the area of maximum tenderness. What is the aim of using of the graded compression technique? It is aimed to displace the bowel loops. انتوا تدرون يعني الابندكس تطلع من السيكم موجود maybe covered by a small bowel loops. So when we use the graded compression technique, we can increase the pressure over this area, and this will can lead to displacement of the bowel loops. The appendix then may be seen overlying the psoas muscle. بهاي الحالة نقدر نشوف الابندكس. So what are the criteria of the ultrasound used to diagnose acute appendicitis? We use the graded compression technique over the area of maximum tenderness using a probe of 7 megahertz or more. Now, what are the signs that can be seen in acute appendicitis? First, a blind ending tubular structure at the site of maximum tenderness. يعني نحدد هذا المكان انه نشوفه لازم blind ending tubular structure نهايتها مسدوده. ثانيا non compressible يعني ايش قد ما اضغط عليها ما راح يختفي عند اللومن. النورمال appendix والنورمال bowel loops when we put a pressure on it the lumen will be obliterated. In acute appendicitis the appendix is non-compressible. The diameter of the dilated appendix is 7 millimeter or greater in diameter. There is no peristalsis. You know that the normal movement of the small and large bowel loop نسميها peristaltic wave. Absence of peristalsis is a clue of the acute appendicitis. وانتم تعرفون انه ultrasound is a real-time imaging can show the movement of the bowel. Appendicolith casting acoustic shadow. قلنا مثل ما نشوف الابنديكوليث بالاكس راي نقدر نشوفها همينة بالالتراساوند و any calcification on stone will show acoustic shadow. وتعرفون شو مصطلح الاكوستيك shadow. High echogenicity non-compressible surrounding fat. The fat that surrounding the appendix it become thick, echogenic and non-compressible. همنا ما اقدر اسوي له compression when we put a pressure. Surrounding fluid or abscess. Surrounding the blind ending appendix we can see a fluid or abscess, and the last sign is edema of the cecal pool. Edema of the cecal pool. From these all signs, the most sensitive sign is an uncompressible appendix with a diameter or 7 millimeter or greater. Non-compressible appendix with a diameter of 7 millimeter or greater in the region of maximum tenderness is a sign of acute appendicitis on ultrasound. تشوفون هنا عندي a blind end tubular structure. هذا هو الابندكس. Thick wall greater than 7 millimeter in diameter with surrounding edema and free fluid indicate acute appendicitis. This is another example. You can see this is the appendix. This is the thick wall of the appendix, and this is a free fluid. This is a blind ending tubular structure with the free fluid surrounding the tip. And also this is a blind ending tubular structure indicating the appendix. However, the high sensitivity and high specificity of ultrasound in the diagnosis of acute appendicitis is depend on the operator because ultrasound is operator dependent. If the ultrasound finding is negative, this does not exclude acute appendicitis. So CT scan is a good alternative for diagnosis of acute appendicitis if the ultrasound is queried. The same feature can be seen on the CT scan as the same seen in ultrasound. A blind ending in tubular structure, thick wall with a diameter greater than 7 millimeter, presence of appendicolith, surrounding inflammatory changes, edema of the cecal pool كلها نقدر نشوفها بالCT scan. You can see this is the appendicolith seen within a dilated appendix. Also, you can see this is a blind ending tubular structure, thick wall with diameter greater than 7 millimeter seen in CT scan. The last topic is the acute cholecystitis. طبعا أكثر شيء نقدر نستخدمه to diagnose acute cholecystitis is the ultrasound. Ultrasound is widely used for the diagnosis of acute cholecystitis. What are the signs that can be seen on the ultrasound to diagnose acute appendicitis? A thick, echogenic gallbladder wall with a hypoechoic margin can be identified in about 50 to 70% of the cases. Thick, echogenic gallbladder wall with a hypoechoic margin. Other signs indicate indistinct contour to the gallbladder wall, a fluid around the fundus of the gallbladder. Gallstones are readily identified and cast acoustic shadows. A stone obstructing the cystic duct may produce a grossly distended gallbladder, so the diameter is also increased. Echogenic sediment may be seen in the lumen, caused by inspissated bile or pus. Other clinical signs used to diagnose acute cholecystitis by ultrasound technique is tenderness of the gallbladder as it lies immediately beneath the ultrasound transducer. It is a reliable sign that the gallbladder is inflamed, and this sign is called positive sonographic Murphy sign. تعرفون إنه الميرفي sign is a clinical diagnosis indicate tenderness at the region of the gallbladder. In ultrasound, tenderness of the gallbladder under the ultrasound probe is called positive sonographic Murphy sign. This is ultrasound of normal gallbladder. You can see there is empty gallbladder, hypoechoic or non-echoic لأنها تحتوي فقط على fluid. The wall is thin, less than 3 millimeter, and the size depending on the state of the fasting of the patient. إذا كان non fasting راح أشوفها contracted، إذا كان البيشنت fasting راح أشوفها distended. Now, what are the signs of acute cholecystitis on ultrasound? You can see thickening of the wall greater than 3 millimeter, hypoechoic surrounding rim, presence of the free fluid, good presence of the gallstone which has acoustic shadowing. Gallstone with acoustic shadowing. نفس الشيء هنا. Thickening of the wall, hypoechoic rim, free fluid surround it, presence of gallstone with acoustic shadowing. Here you can see, here you can see the gallbladder is dilated, contain stone. This stone has acoustic shadowing. This is sediment, echogenic sediment, and this echogenic sediment could be due to inspissated bile or due to pus, thickening of the wall with surrounding edema surrounding the fundus of the gallbladder. هل لازم كل هاي الأشياء موجودة يلا نشخص acute cholecystitis؟ طبعا لا. الأهم شيء بالdiagnosis of acute cholecystitis is the thickening of the wall greater than 3 millimeter in diameter with edema of the wall of the gallbladder. And you know that most of cases of gallbladder in 95% of the cases is calculus cholecystitis. So usually we can see stone within the lumen of the gallbladder. Gallbladder is ultrasound is highly sensitive and specific for the diagnosis of acute cholecystitis other than any radiographic technique. وقلنا tenderness of the gallbladder as it lies immediately beneath the ultrasound transducer is a valuable sign indicate acute cholecystitis, and this sign is called positive sonographic Murphy sign. The last topics in our lecture is the diaphragmatic hernia. Diaphragmatic hernia is herniation of the abdominal viscera into the thoracic cavity occur through either diaphragmatic hiatus, which is called sliding and paraesophageal hiatus hernia, or a congenital defect, which is called Bogdalic and Morgagni hernia, or through a diaphragmatic tear. الكومنست اللي احنا دائما نشوفها هي السلايدنج هيتس هيرنيا. sliding hiatus hernia. It is the commonest type of diaphragmatic hernia. What are the signs of sliding hiatus hernia? It is defined as a bulge of stomach that protrude more than 2 cm above the diaphragm. Normally, less than 2 cm of the stomach can be seen above the diaphragm due to good functioning of the ligament that is called the phrenicoesophageal ligament. This good functioning ligament allow movement of the stomach less than 2 cm above the diaphragm. So if we see a bulge of stomach that protrude more than 2 cm above the diaphragm, this indicate a sliding hiatus hernia. 3 or more gastric folds may be identified passing from the stomach across the hiatus. شوف 3 or more gastric fold above the hiatus. The hiatus is wide, measuring more than 3 cm in diameter. This seen on CT scan, we can measure the distance between the crura of the diaphragm and we can measure the diameter of the hiatus. If it is greater than 3 cm in diameter, this indicates a sliding hiatus hernia. You see that here there is a large pouch of stomach extending more than 2 cm above the diaphragm, containing 3 and more rugae with wide hiatus greater than 3 centimeter in diameter. And this is another example of hiatus hernia with a large pouch of stomach seen above the diaphragm. The most common and most clinically present congenital hernia is the Bogdalic hernia. Bogdalic hernia is usually due to defect in the closure of the posterior aspect of the diaphragm on the left side. We usually may present as a case of respiratory distress syndrome in the early infancy. What we can see on a plain abdominal film or on a plain abdominal film or on a chest radiograph, we can see herniated bowel and herniated bowel can be seen extended from the abdomen into the left hemithorax. There may be malrotation of the bowel loops due to difficult of normal rotation due to presence of the diaphragmatic defect, and the diagnosis may be difficult on chest x-ray or on plain abdominal film if the herniated content is the liver of spleen or the bowel is still fluid filled. قلنا هو البرزنتيشن يكون بالايرلي infancy. So if the bowel is still fluid filled, it's difficult to diagnose on the plain film. If the content is spleen or stomach or kidney, it is difficult to be seen on the plain film. So we require a contrast film for showing the bowel loops that extended into the bowel. So the sign of Bogdalic hernia is multiple bowel loops extended into the hemithorax. Contrast study also will show multiple dilated bowel loops containing contrast extending into the hemithorax, the left hemithorax. It is important, the Bogdalic hernia is important because it may present with respiratory distress syndrome in infancy. So the object of our lecture is to deal with the different type of acute abdominal condition, to know what are the best radiographic technique and what are the obstacle of using of this radiographic technique, to know what are the alternative if the radiographic technique finding is a query or non-conclusive, and we can also assess different type of diaphragmatic hernia. Any question? Okay, thank you.